Before we get started, what this presentation is not. It's not a roundtable discussion on the latest science on COVID-19. It's not about the medical care. It's not about any of the science behind this pandemic. What it is about tangible case studies and real life experiences from 3 different areas across the nation on how they're managing COVID-19, and more importantly, what lessons they're learning to manage their EMS system going forward. So with that, we're going to start with Colorado Springs. In the Colorado Springs area, we have 2 medical directors with us today. Dr. Stein Bronski is a good friend of mine. Dr. Bronski began his EMS journey as an EMT in 1991. He attended medical school at Vanderbilt University in Nashville, Tennessee, followed by his emergency medicine residency and EMS fellowship at Virginia Commonwealth University in Richmond, Virginia. He has over 12 years of post-fellowship EMS medical direction experience, including medical direction for both air and ground EMS services. He is currently the Chief Medical Director for the Colorado Springs Fire Department, the El Paso County AMR Ambulance Service, and the El Paso Teller County 911 Authority. In addition, Dr. Bronski is a member of the Eagles Consortium. With him is Dr. Matthew Angelitis. Dr. Matt is a board-certified emergency physician for UC Health at Memorial Central, Memorial North, Pikes Peak Regional Hospital, and Grandview Hospital in Colorado Springs. Dr. Angelitis is the co-medical director for Colorado Springs Fire Department and AMR. He's also the EMS County or El Paso County EMS medical director and the co-medical director for the Plains to Peaks RETAC and the UC Health EMS medical director. He's been participating in the development, implementation, training, education, and quality assurance for pre-hospital providers across the Plains to Peaks region. Welcome, guys.
Thank you for that very kind introduction, Chris. This is Matt Angelitis. I think I would start with a little context. Dr. Bronski and I live in Colorado Springs, Colorado. It's the other city in Colorado besides Denver. We're currently in El Paso County, which is roughly 650,000 residents. The city itself, city proper, is 470,000 residents. And that is healthcare shared amongst 5 major hospitals across 3 hospital systems, Children's Hospital and 2 others. And we manage about 85,000 911 calls a year. So just a little context for the city that we're living in.
Yeah, so we have been using mobile technology for a few years now. One of the mobile technologies that we do use is EM Resources. I'm sure a lot of people listening in to this webinar are familiar with EM Resources. Typically, historically, it's used for hospital-to-hospital communication, for bed status information, and also for MCIs to figure out and coordinate what beds are available in hospitals. We took this existing EM Resource system and repurposed it to show our field crews, EMS field crews, real-time information on service line ability in the hospitals. And so on this screen, you'll see on the right side, there's a screenshot that says status. That just is a screenshot of what a crew member or a supervisor in the field can see when they are in EM Resources on their mobile device, and they can look at each individual hospital and see all of the different service lines and know which one is immediately available and which one is not available, so that we can help direct traffic. And that is something that we plan to use and actually make even more robust into the future.
So guys, the second piece of mobile technology that we are heavily leveraging in our community is the Pulsera pre-hospital communication system, which Chris already introduced to you, the basic nuts and bolts. In our community, we implemented Pulsera approximately 4 years ago, primarily to initiate communication channels for a patient with regards to STEMI, ST elevation MIs, and stroke alerts. So in real time in our city and in our region, an EMS provider is able to activate an ST elevation MI alert from the field, and that communication from Pulsara simultaneously sends the EKG, patient's vitals, age, meds, risk factors to the hospital system that they are transporting the patient to, so that the ER physician, a charge nurse, the cardiac catheterization lab team, as well as the interventional cardiologists are all aware of this patient's location within the city and expected time of arrival and their current condition. We have started under COVID-19 to leverage Pulsara in different ways within our community, and we're expanding its use across multiple other avenues such as trauma as well.
So speaking about Pulsara use in the existing pandemic, when COVID-19 hit our community, we immediately recognized that our vision of needing to have immediate telemedicine capability from the crews in the field to the medical directors was an immediate necessity. It wasn't something we could wait a long time for. And the logical choice was to use Pulsara in an expanded way, because everybody already uses it. Every EMS provider has it. They're used to using it for the EMS to hospital communication. And using the existing platform, we could also flex it to start telemedicine consults directly from providers to medical directors. And that could help us within the pandemic crisis to use medical directors when necessary to figure out if people should be transported. Matt will talk a little bit about that in just a minute. Another thing that we recognized was that we could use an expansion on Pulsara to use it for telemedicine consult between a provider and a patient directly, and the EMS provider wouldn't necessarily have to be present with the patient. And we'll talk about more of these. The main thing here is that we wanted a product that we didn't just start up because of the pandemic. We wanted to use an existing product that we knew worked well that could flex into and out of pandemic situations.
Yeah, I think that's great. What I'd like to do now is kind of give you guys some real-time case examples. And the first thing I have to do is sort of review one of our pre-hospital algorithms. So we initiated a non-transport algorithm for potential coronavirus patients under the idea that not every person experiencing coronavirus symptoms would best be served by being transferred to an emergency department. Obviously, that utilizes a lot of PPE. It exposes our pre-hospital healthcare providers and emergency room staffs unnecessarily. And so we utilize CDC and World Health Organization information, and we developed the algorithm that you see on your screen. Essentially, patients are walked through two boxes on the left-hand side of the screen. We have a set of objective criteria. Those are things that would obviously cue the provider into knowing the patient has to go to an emergency room, like abnormal vital signs. And then box B, which is sort of our more subjective criteria or risk factors. These are things that we know result in worse outcomes for COVID patients. And what I would like to do is just walk you through a case of a very young lady named Lois, a 78-year-old female, who called our 911 for evaluation of cough and shortness of breath. Our EMS providers arrived, and they identified that Lois had normal vital signs, but that she is an elderly female, 78, which places her at higher risk in the setting of coronavirus. If you follow our algorithm, that puts us in that middle category. She's negative for box A, but positive for box B. This then guides our EMS teams to initiate alternate avenues of access to healthcare. The first one on the list is to initiate a telemedicine consult. Next slide. So what you're going to see now on your screen is on the right side there, you have an EMS provider wearing a PPE, a mask, and in the top right corner, you have Dr. Bronski sitting on his couch at home. And what we've done is this provider has activated a Pulsara case for Lois, which then pings our medical direction command team. So Dr. Bronski is on call for the day, and he gets the notification on his phone that our EMS crews have a patient they'd like to discuss with him. Dr. Bronski is able to click into the patient, initiate the teleconsult that you're seeing on your screen there, and in real time, he takes a history, discusses the issues with the patient, is able to look at her in real time, and even direct the EMS providers to perform certain tasks. For example, listen to their lungs again, or repeat a set of vital signs.
And through that, the EMS direction team can help providers figure out who may need to be transported, who can stay on scene. Another way that we are leveraging Pulsara now is to use what they call Pulsara Patient, which is a platform that gives us the ability to push an invitation to a patient directly from a provider. And that provider could be an EMS crew, it could be a physician, it could be whatever provider needs to get in contact with that patient. And the patient can then open up the portal and we can have discussions back and forth. I'll give you just a very brief example. We have a patient here in town, it's a child that has a really bad seizure disorder. And on top of that, unfortunately, has some airway and respiratory issues also. So they're at high risk for developing some airway compromise when they have seizures. And so historically, every time the child has a seizure, they call 911 just for backup on this child's airway if needed. Well, right now, every time we encounter this patient, we have to use PPE, we have exposures because somebody in the house is COVID positive, and we want to try to avoid that if we can. And so we push an invite to the family who then can speak to a provider that's sitting outside of their house, and they're staged and waiting, and if the child resolves and doesn't need any airway management, then we can communicate that directly from the family to the EMS providers, and then they can leave, and we have not wasted PPE, we have not exposed people unnecessarily. The last thing I'd like to mention is that the Pulsara Patient also gives us the capability of following up with patients. So if we run on a patient that's a COVID patient like Matt was talking about, but has been left at home, then the next day we could ping them again and talk to them and video conference with them. And so all in all, Pulsara has been a tremendous advancement in our capabilities to interact with the patient population during the COVID crisis. And there we'll stop and hear about other people's.
Yeah, Dr. Matt, Dr. Stein, that was fantastic. Thank you. As we move through here, there are a handful of questions, and during this transition time, I will hit a few of them as we move into Austin. There's a handful of questions asking about secure, and I do think that secure telemedicine is critically important. I'm not sure if people are asking about Pulsara in particular, but yes, Pulsara is HIPAA compliant. It is secure, it's encrypted at both ends and at rest during the entire patient process. We also do entire vetting with the hospital systems with their IT group prior to implementation. And then as we walk through this, another question was asked about, does Pulsara access the e-medical records and how does that whole thing work? And we do have integrations, both the ability for EPCR integration as well as EHR. And more importantly, at this moment, as you'll see in these following case scenarios, and what Dr. Matt and Dr. Stein just said, is that this is about real-time communication. So instead of pagers, fax machines, and answering services, we're able to use mobile medicine to take care of the patient right now with those signs and symptoms. And some of these other questions will be answered as we get into these next case scenarios. So let's jump into Austin, Travis County with Commander Chris Lester.